Hi everybody, my name is Sarah. I'm going to be doing a presentation on the Whipple procedure and post-operative nursing care. More specifically, nursing care that happens on an unmonitored unit. So at the end of this presentation, I would like you guys to be able to recall indications for a Whipple procedure, describe changes in anatomy during a Whipple procedure, describe nursing interventions during the post-operative monitoring period, explain different types of drains used post-operatively, and interpret the different types of Jackson Pratt drain output that can occur post-operatively. Also, recognizing common complications of the Whipple procedure. All right, so some indications for the Whipple procedure most commonly are pancreatic cancer at the head of the pancreas. We also perform the Whipple for patients who have pancreatic cysts, pancreatic tumors that are non-malignant but that might eventually become malignant, pancreatitis, ampullary cancer, so cancers that originated in other parts of the body and then metastasized to the head of the pancreas. We also do this surgery for small bowel cancers in the duodenum, neuroendocrine tumors, bile duct cancers, and trauma to the pancreas or small intestines. So the Whipple procedure is a very complex surgery that requires about 5 to 6 hours for the surgeons to perform the surgery. So before the Whipple surgery, you have your stomach that's attached to your duodenum and then your jejunum. And then you have your pancreas connected to your duodenum, and then your gallbladder connected to your duodenum also. So during the Whipple procedure, first and foremost, you remove the tumor and resect all the margins at the head of the pancreas. So that would be like right here. And then what the doctors do is they also remove the first part of the small intestine, which is the duodenum, the gallbladder, the bile duct, and then also at times the spleen. So they're taking out this whole bile duct, this whole part of intestine, the head of the pancreas, and all of the gallbladder. That all goes away. And then what they have to do is reroute all the organs and reattach them together. So the point at which the organs are reattached together is called the anastomosis site. So there's going to be 3 anastomosis sites after the Whipple surgery is complete. So the first anastomosis site connects the pancreas back to the small intestine, and that's called the pancreatic jejunostomy, or the PJ connection. Then you have the connection, the reconnection of the stomach back to the small intestine, which is called the gastrojejunostomy, or the GJ anastomosis. And then last but not least, you have the reconnection of the bile duct to the small intestine, and that's called the hepatic jejunostomy anastomosis, also known as the HJ anastomosis. So you can see how this surgery is so complex and how many complications can arise just from the reconnection of the anastomosis sites alone. So here I have a video of the Whipple procedure. Dr. Cameron narrates the video, and he really does a great job of kind of simplifying the procedure and explaining exactly what happens during the surgery. So post-operative monitoring. This is the part of the presentation we're going to focus the most time on. Patients immediately post-op will go right to the intensive care unit. Since the surgery takes 5 to 6 hours at least, we want to make sure that these patients, they need frequent cardiac monitoring, continuous cardiac monitoring actually, and frequent hemodynamic monitoring so that ICU is the safest place for these patients the first 24 hours recovering from surgery. And then once the surgical team and the intensivist down in the ICU deems that the patient is safe to come up to an unmonitored floor, the patient will come to us. So one of the most important parts of post-operative monitoring in nursing care is going to be the vital signs that we take every hour. Any abnormal vital signs need to be reported to the physicians, and vital signs can be very indicative of any post-operative complications such as infections or bleeding. We also strictly monitor patients' intake and output every 4 hours. So since you're rerouting the intestines to do this complex surgery, the bowels aren't going to work immediately the way they used to before surgery. So these patients are typically nothing by mouth, and we need to make sure that the IV fluids that we're giving them are appropriately hydrating them. We also check patients' blood sugars every 4 hours post-operative, immediate post-operatively. So anytime that you have someone who's nothing by mouth, you want to make sure they don't become hypoglycemic. But another big part is like you're resecting the pancreas. The pancreas produces insulin. So when you take that insulin naturally made from the pancreas, these patients are at increased risk of having actually too high of blood sugars and becoming diabetic. So we want to make sure that if they are showing signs of hyperglycemia and diabetes, that we start teaching insulin regimens to them before discharge. We also monitor patients' daily weights every day. We want to see if they need to be diuresed and get some of that extra fluid that we give them from surgery off of them. We also monitor daily labs, so a complete metabolic panel that tells us what the patient's electrolytes are, liver function, kidney function, and we also check their bilirubin levels just to monitor how high they are. We also order a complete blood count, so that helps us monitor what blood cell counts, red blood cells, platelets, and hemoglobins, which can, white blood cells, high white blood cell counts can be indicative of infection, and then low hemoglobins might mean that a patient is bleeding. So at the start of your shift, you should also always do a full head-to-toe assessment. This full head-to-toe assessment gives you more insight into the patient's needs and any complications that they might be experiencing. You also want to make sure that you ambulate your patients early. So post-op day 1, when patients are in the ICU, we have them up and walking. Early ambulation prevents against blood clots, pressure ulcers, pneumonia, also prevents against constipation and increases GI motility, which is really important in this population. Another really big part of your nursing care is going to be administering medications to help to optimize recovery. So that means administering pain medicines per order. A big part of that is administering narcotics. These patients typically have the PCA pumps, so you have to make sure that they're safe using those. And then eventually, as patients transition and start eating and drinking more, they'll transition to pain medicine by mouth. So you want to make sure that you're educating patients on why they're taking these medications, side effects of these medications, to keep them safe at home also. These patients also experience a lot of post-op nausea and vomiting. You're rerouting all these intestines. They tend to get nauseous, so you'll administer a lot of antiemetics per order. So Zofran and Phenergan are probably the 2 most common ones we administer. We also every patient has some form of like blood clot prophylaxis. So either heparin shots, Lovenox shots, or heparin IV. And then you also want to make sure that you're the eyes and ears for the patient. The doctors, come in for morning rounds and afternoon rounds, but you're the one who's with them all day. So a really big part of your nursing care is also reporting abnormal findings to the providers. Abnormal vital signs, abnormal assessments, abnormal drain outputs, abnormal lab values. You want to let the providers know so that we can do interventions and take care of these patients appropriately. All right, so I have here a box with the different kinds of drains and dressings that these patients might have. So I'll let you guys take a look at these. So every patient's going to come out of the operating room with a nasogastric tube. So this nasogastric tube goes in through their nose and down into their stomach, and it decompresses their stomach so that you don't have anything running through the new anastomosis sites and give them time to heal. All patients also need to have some form of peripheral or central line IV access. Since they're not having anything to eat or drink by mouth, want to make sure that we have a way to hydrate them through the IV. We also want to make sure we have a way to administer pain medicine and antiemetics and antibiotics as needed. These patients also some patients will have large abdominal incisions, or we can also perform the Whipple procedure laparoscopically. So with the laparoscopic procedure, patients will have 1-inch incisions that are covered with Dermabond, which is glue, and they'll be like around the abdomen. They'll just be open to air. And then if patients get an open Whipple, they'll have the large midline incision. So that one comes with the wound vac. So what the wound vac does is it uses suction and it slowly sucks the patient's skin together and heals the wound. It's a closed system, so what you'll see is a dressing with a tube connected to a machine, and the machine provides the suction that slowly suctions the wound together. Patients are also going to come out of the operating room with 2 Jackson Pratt drains. So anytime that you cut through organs release fluid, and it's the job of the Jackson Pratt drains or JP drains to collect this fluid and prevent against intra-abdominal infections. Patients also come out with a Foley catheter to keep strict output of their urine output. So JP drainage, what does it mean and why is it so important? So normal JP drainage is this zero sand color, so it's light to dark red color that almost looks like Hawaiian punch. Another normal JP drain output is serous. So serous is that clear yellow color. That's also normal. When you start getting worried, when you start to see bile come out of the JP drain, so that's a green, yellow, oily consistency. And that can mean that the patient has a leak from their HJ anastomosis. So that's the connection from the bile duct to the small bowel. Another cause for concern is that the JP drain outputs turn tan, opaque color, and it's also a thick, cloudy consistency. That can indicate a leak from the PJ anastomosis. So the connection between the pancreas and the small intestine. So the pancreas produces a bunch of enzymes that help with digestion. So when the pancreas releases these enzymes and they don't make it in the small bowel, they come out of the JP drain. So that's what that tan color is. Another color you'd be concerned about, if the drain output looked like milk, it was a milky white color, that could indicate a lymphatic or chyle leak. So during surgery, the surgeons accidentally nick the lymphatic system and it's draining out through the JP drain. And one of the most serious JP drain outputs to look out for is sanguineous output or bloody output. That could indicate a GI bleed or arterial venous bleed from the surgical site. And you would immediately want, if you saw blood coming from a JP drain, you need to immediately get vital signs, assess your patient, and call the providers. So that's sanguineous output right there. That's really bloody output. And then this is output from like a chyle leak. All right, so I've been talking to you guys for way too long, so I have a little game for us. We're going to break up into groups of 3 to 5 students. I'm going to provide your group each with containers of JP drain output, and I want you to identify what kind of drain output it is, and if it's abnormal drain output, identify kind of what a leak the drainage indicates. All right, so you guys have 5 minutes to work in your groups, and then we'll discuss your drainage. All right, great job. Everyone did an awesome job identifying their drainage there. All right, so now I'm just going to get to the common complications of the Whipple. So the most common complication is something called delayed gastric emptying or DGE. This is when the contents of the stomach are unable to pass from the stomach into the small bowels. These patients will typically experience persistent nausea and vomiting, abdominal distension. What'll usually happen is when you notice that someone's either had an episode of emesis or their abdomen's grossly distended with hypoactive bowel sounds, you'll notify the provider. The provider will order an abdominal x-ray or make the patient nothing by mouth for a couple more days. If the abdominal x-ray doesn't look all that great, we'll have to reinsert an NG tube, which I have to admit is like my least favorite thing to do in nursing. Another complication is bleeding at the surgical area. So that's when you see blood coming from the JP drain. Patient has changes in mental status, they're diaphoretic, they're pale, they have changes in vital signs. That's considered a medical emergency and you would immediately want to notify the providers. And that patient might have to go either back to the operating room or go to a higher level of care. I would say the next most common complication is infections. So these are intra-abdominal abscesses that form in the patient's abdomen. What we'll have to do is send those patients back to interventional radiology and they'll get another drain place called an abscess drain that will drain that fluid and they'll be started on antibiotics. Another one is, like we kind of touched on earlier, leakage from the pancreas, which would cause that TAN output from the JP drain. These patients will be made nothing by mouth to allow for their pancreas to heal. If the leak is significant, then they'll have to be made NPO for a significant amount of time, sometimes up weeks to months, and get a central line and be put on IV nutrition. The other leak from the bile duct, so that's when the JP drain turns bilious. These patients have a leak from their bile duct to their small intestine, and they'll sometimes need a stent placed in interventional radiology or have an external drain placed. And the other complication is diabetes, so that's why we monitor these patients' blood sugars every 4 hours post-operatively. And if they need any kind of insulin regimen at home, the nursing will do all the education for that. All right. So in summary, the Whipple procedure is typically performed on patients who have tumors located at the head of the pancreas or in adjacent areas such as their bile duct and duodenum. Nurses need to notify providers of abnormal vital signs, drain outputs, physical assessments, and lab values to keep the patient safe. JP output is an important part of the nursing assessment and can indicate anastomosis leaks and complications of surgery. And the Whipple surgery is one of the most difficult and complex surgeries. Nursing should always be aware of the high rate of complications these patients experience. If there's no complications, the post-operative recovery period can be as little as 7 to 10 days, or I've had patients on the unit for 3 months recovering from the surgery. All right, so now I have a little case study for you. So Mr. Green, he's post-op day 4 from a Whipple procedure and currently on a clear liquid diet. Upon assessment, you notice that his abdomen is distended, bowel sounds are not present, and the patient is not having flatulence. Patient reports having nausea throughout the night, and patient also reports not being interested in drinking any liquids. Several hours later, the patient has an episode of 500 milliliters of bilious emesis. So what common complication do you think this patient is experiencing? Yep, you're right. It's delayed gastric emptying. So what are some nursing interventions that you would provide for this patient? Yep, administer antiemetics, he'd be NPO again, and at times you might have to reinsert an NG tube, unfortunately. All right, I have one more case study. So you're caring for Miss Brown. She's a 65-year-old female with a history of pancreatic cancer. She post-op day 2 from a Whipple procedure. Her vital signs at the beginning of your shift are normal. Upon her assessments, also benign. ANO*4, her abdomen's round and tender from surgery, and her 2 JPs are serosanguinous. A couple hours later into your shift, the clin tech calls you in to the room stating that the patient just doesn't look right. The patient's pale, she's diaphoretic, and having a change in mental status. Both her JPs are filled with sanguinous fluid, and her abdomen is grossly distended. Her vital signs are as follows: low blood pressure, high heart rate, high respiratory rate, high temperature, and low oxygen. So what common complication do you think this patient is experiencing? Bleeding, right? Absolutely. So this will be a medical emergency. So what nursing interventions would you provide? Yep, you're right. If I saw this patient, I would immediately, get vital signs. If I saw those vital signs, I'd be hitting the emergency button, calling in the providers, and probably calling a rapid response. So this patient's deteriorating pretty quickly, and I want to make sure she gets the appropriate level of care. All right, guys. Well, thank you for listening to my presentation on the Whipple procedure. If you have any questions about my presentation or just the procedure in general, please feel free to reach me at my email address, and I'll also be staying late after the class to answer any questions that you may have. Thank you.
That was great.